I'm Steve Macfarlane. I'm the Head of Clinical Services for the Dementia Centre. So I supervise a team of medical practitioners who provides advice to the severe behaviour response teams and the DBMS program. SBRT was set up in late 2015 to manage the most difficult referrals with behaviour in dementia in Australia. So you can conceptualise lower level behaviours and very severe behaviours. The severe behaviour response team was set up to target the top of the pyramid, if you like, whereas DBMS, the Dementia Behaviour Management Advisory Service, targets the lower level behaviours. But it's a national service that operates across Australia in a consistent manner. It's human nature to look for a quick fix. People would like to believe that there's a simple way of medicating away a problem, but these behaviours have their roots in complex, multifactorial origins, and a one-size-all approach, least alone one involving the prescription of medications, just doesn't work and is frankly dangerous. The behaviour is the symptom. I mean, people are referred because they have been identified as having a behaviour, but we don't actually treat the behaviour. We look for the cause of the behaviour and treat that. Well, our consultants spend some time on site analysing not only the progress notes of the patient, but talking to the person living with dementia themselves, talking to family members, talking to the general practitioner, spending a lot of time talking to the on-the-ground care staff who provide the face-to-face care. The approach prioritises learning more about the person, with the theory in mind that the behaviours are due to the lack of something that the person needs. And to know what the person needs or wants, you need to go back into their personal life to find out what their specific likes and preferences are. So we take a detailed personal history, and that information forms the backbone of any recommendations that we might make about managing the so-called behaviours. So what we've done with the SBRT recently is analyse the data from our cases and looked at the levels of behavioural disturbance at the point of intake into the service and at the point of discharge. And we've found that we've been able to decrease behaviours by changes in the order of 60 to 70%, which is really dramatic. It's much more than what medication can achieve. It's much safer as well. And we've been able to do this by not increasing the amount of medication that people are prescribed. So our outcomes have been achieved by putting behavioural and psychological interventions in place without really altering the rates of psychotropic prescription at all. There's not a one-size-fits-all approach. Every individual has their own unique personal background and set of likes and dislikes, the knowledge of which informs how to manage any behavioural symptoms they might display. So we can't get around that step of taking a detailed personal history and coming to a closer understanding of the person before we can manage the identified problem. I'd like to see us defocusing on behaviour as the problem. Behaviour is the symptom. We need to start thinking more about the causes of the problems and treating those. I would like to highlight that the rates of psychotropic medication prescription in Australia in nursing homes are extremely high. I think that these medications are actively doing harm to people, and we owe it to our vulnerable older persons living in residential care to take a behavioural and environmental approach to solving their problems rather than resorting to pills which actively do harm.